All right. Hello and welcome, everyone. I'm Shali Siddiqui, your host today. I'm absolutely thrilled to have you join us for the webinar on health system solutions. I promise this will be far more engaging than the usual waiting room at the doctor's office and no long waits. So today we're going to dive into some of the most pressing challenges and exciting innovations shaping our health system. We will explore how collaboration and cutting-edge technology are paving the way for better patient outcomes and most efficient health care delivery. As we go through, I encourage you to think about the current systems in your communities and how we can collectively build solutions that are more inclusive and effective. It's all about empowering communities and co-designing better health system together. We have an incredible lineup of experts today. Our first speaker is Dave Sounder. Dave is former mayor of Colwood in British Columbia, and he owns non-for-profit companies, Saunders Family, and also Health System Solution in BC. He will kick things off by sharing insights and our second speaker, Dr. Helga, Provost at UVic, University of Victoria. And we will have a dynamic discussion afterward with her. It's going to be an informative and engaging session, so stay tuned. So just before you go ahead, Dave, I wanted to, before you go ahead and share your insight, what's happening in BC, I want to share exciting news that happened in Ontario this week. So Ontario Deputy Premier and Minister of Health Sylvia Jones announced a major investment of 1.1 billion to expand and modernize home care services across the province. And what does that mean? 982 million over 3 years to enhance core home care services such as nursing, physiotherapy, and social work. And second, 170 million to expand the hospital to home. We call it H2H program, aiding patients transition from hospital and community. So this H2H program will increase from 47 to 88 sites, supporting thousands more patients. So that means that we will have more free beds at hospitals for patients in need. I think that's very exciting. Let's see how this unfolds as we move forward. Yeah, I wanted to share this. And the second item I wanted to share, these educational webinars that we try to offer monthly and share insight and learn from each other is through a non-for-profit company called Q Care Hub Association, and hopefully that we continue on monthly basis. Yes, so without further ado, let's dive and hear from our amazing speaker, Dave Sander. Go ahead, Dave.
Thank you, Shelley. That's a gracious introduction. So, a bit of my history. Yes, I'm a former mayor, former councillor, but I've been in business for, I don't know, 38 years now. Our family is very entrenched in the Victoria area. We give back to the community through our Saunders Family Foundation. I also helped to develop a program called the Comfy Kids Program, very similar to Hope Air, but not quite as grand for the rural areas, as we supply a vehicle transportation for children that are affected by cancer over to the Children's Hospital in Vancouver. So basically, after a couple of years, families are destitute when their child has cancer, and they've scraped together all the funds that they can. But this vehicle and support network provides a vehicle for free for these families. So that was a pretty cool initiative. But so uh, 4 years ago, I met with John Horgan and started what we call a playbook and a toolkit to embed support into communities. In that, I think that we all have a collective responsibility as Canadians to send a signal of hope to doctors, nurses, and emergency responders. And the reason I say that is because my daughter, and my family and my dad have experienced healthcare situations that our system saved them, and so we wanted to give back. But being a former mayor and chair of planning and zoning for a long time, I realized that we as communities weren't doing quite as much as we could in relation to supporting doctors, nurses, and emergency personnel. So I hired through our foundation Mark Holland, who is a very well esteemed and respected planner in our area. And we took about 20 different solutions to the premier, and he said, these are good, sound solutions that embed community into what we're trying to achieve to help support healthcare. And he sent me down to Ministry of Health. And 4 years later, we now have a playbook and a toolkit out. It can be referenced through my email at saund@telus.net. So saund@telus.net. You can see the links to that playbook. But more importantly, it provides solutions to communities, whether large, small, rural, urban, whichever. Um, and there's a lot of solutions embedded in the playbook and toolkit that most people don't realize. Everybody, in my opinion, kind of finger points at either the province or the federal government or Island Health or Interior Health to solve their problems, when in fact, most of the problems of supporting doctors and nurses come from communities themselves. So as an example, yesterday I met with the city of Colwood. I'm bringing forward a brand new concept related to senior care that involves family members being side by each in a new building design, and also caregivers and virtual type care, but also 9,000 square feet of clinic space for doctors and nurses. And you may find this shocking, but that 9,000 clinic space will be delivered free of charge to the municipality based on the density increases associated to this development. What I've also learned through this process is that there's 18 different ministries that can help support uh, Ministry of Health, because everybody finger points at the Ministry of Health, but actual fact that we can prove and qualify through our new company, Community Healthcare Systems Inc., that I developed as a benefit company to roll this work out, is that we can prove unequivocally that these other areas of ministries can help with the to support what we are in a type of crisis situation across Canada as a whole. So when I see Kicking Horse and when I talk about Cranbrook and Golden, and you talk about transportation issues and housing, well, the RCMP are supplied, the young generation of RCMP are supplied housing when they cut their teeth as an RCMP member, but we don't supply housing specific to supporting doctors, nurses, and emergency responders. So you can't go to the Ministry of Health and ask for that, but you can go to the Ministry of Transportation and also housing for that. But then you can also link in the economic driver of Ministry of Innovation. And so our new company derives solutions that way, that embeds other ministries into community. Because right now communities aren't taking advantage of the grants that are associated to some of this work. I also work with the South Nation and the Beecher Bay Nation on looking at how we can roll out different optometry type of virtual optometry to their nations, and we could distribute that through all of BC. But when we went to apply for a grant and a business license, or a business case actually, to all the different granting authorities, they didn't see healthcare as an economic driver. They didn't see it as a job creator. But when you do a simple Google search, is that one of the largest employment sectors in all of BC is healthcare. And I come from a resource sector myself, so former fisherman, trollerman, way back in the day, over 35 years ago, and then a logger. And my family is up north in Fort St. John, both farming and in the gas industry. But those resource industries don't supply the equivalent of healthcare, or the equivalent of jobs associated with healthcare. So in business, for me, for the last 38 years, I see it as an economic driver that we're not taking advantage of, because we're too busy finger pointing at the federal or provincial governments to say, well, this is your responsibility. When in fact, Colwood, my hometown here, has taken advantage of it. They thought outside of the box with myself and my team to develop a clinic space, and they are looking at healthcare as an economic driver for their region. And the the basic need in our community is healthcare, but also its economic stability. We're working right now on a resiliency plan reflective of creating resiliency for even small towns and urban centers, um, because healthcare is a stable industry that creates good, well paying jobs, but we're not taking advantage of that to the degree that we can. So, this playbook and toolkit and this new company that I've formed, the Benefit Company, helps communities do exactly that. Figure out how you can transition your town into a resiliency town related to healthcare, secure more housing, and secure the grants associated to all the 17 different ministries that can help, not just finger pointing at the Ministry of Health, because they're under a lot of strain and a lot of stress, and they're trying to do copious amounts similar to interior health and island health. They're trying to manage everything on a shoestring, yet all the other shoestrings involved to complete the shoe aren't working together. So my job, I think, is to pull those together in a positive way, with solution orientated.
That's great. Well, thank you. It's amazing that you mentioned we shouldn't finger point at health minister. There are 17 other ministers that they can help out with healthcare. Um, that's great. You know, I was part of House of Commons, but I learned this just now. Well, thank you. Yeah. So, Dave, what are the challenges right now you're facing? Now you have your playbook out. It took you 4 years to prove yourself to government that you can do this. What are the challenges that facing now?
Well, I think the challenge everyone is facing is that we're seeing the largest deficits in both the federal and provincial jurisdictions. You're seeing budgets that we've never seen before. You're seeing this lunacy of tariffs. So we really need to think outside of the box. I've been doing this off the side of my desk, collecting zero money to do this. I'm going to continue to do this work. I was somewhat promised by the province because they wanted, selfishly, I wanted this just for the West Shore area in Victoria, this playbook and toolkit. But the province thought it was such a good idea that they said, well, why don't you roll it out to all of BC? I said, well, that's fine to do. I said, I'm doing it off the side of my desk. I have great consultants related to healthcare, planning, lawyer, uh, communication. We have an economist that we can derive and improve feasibility with a lot of the planning that we're doing. But that takes funding. So with the with the funding crunch, we're not being funded by the province to do this work. So we're thinking outside of the box. I just hosted a golf tournament up in Lake Cowichan on the island here, where we raised approximately $30,000 to facilitate regional planning for Lake Cowichan through resiliency. It's called a resiliency plan that we're working on. Because what I learned in municipal politics was that um, you have to think outside of the box and you have to look at other sources of income when you don't have that income. Looking to the other ministries associated to healthcare and qualifying those asks of those different ministries through proper, like a checklist, through basically a qualifying report that proves that we can change that delivery of healthcare related to housing or related to transportation. As an example, when I presented up in Kelowna to the Rural BC Network, Hope Air was there, and they do similar things. Is that they raised a ton of money to try and take care of rural citizens that need to travel for healthcare. When I brought forward that on the island here, the Ministry of Transportation and of Highways funded a program, a walk to school program, related to 7 different schools to the tune of $1.2 million. And they funded that because there was a net benefit of the reduction of traffic related to walking kids to school. And when I looked at Hope Air's travel plans and how many travel destinations they actually achieved in that year, I could prove unequivocally that not only did they reduce traffic, but they reduced the environmental footprint related to that traffic being on the road. And those are the type of things that we can do to prove to municipalities or individuals or other companies that you can approach different ministries in a different form rather than just approaching the Ministry of Health for these circumstances.
Mm-hmm. Well, thank you. That's amazing, Dave. You're doing really hard work for your community. I know that you advocate for Aboriginal, for Indigenous community too in northern BC. Could you tell us a bit about that?
Yeah, so I sit as a director. I've been privileged to sit as a director for the Tasauk Nation on their two new societies, one environmental and then one economic. So when I brought to them the opportunity to create Opta Canada, which is an optometry virtual care company that can be distributed to each rural community. So a lot of the rural communities, nations, and also say the smaller areas of Hope or whatever, they don't have a lot of optometry options. So this is a virtual optometry company that could be organized throughout BC and basically visit each nation with a traveling unit. Then they get optometry care. But we're in the early stages of trying to secure that business case, but that's achievable. It's a it's a sound type of optometry company that could it's virtual. It could be templated across all of BC. And that what I've learned through when I took a nation member there from the Tasauk community and the band health officer, they were absolutely blown away by the care that this one individual received at the time and went through the entire procedure of optometry, but also ended up with a set of glasses coming out within 2 hours. But more importantly, this member had had a stroke 2 years previous, and this eye exam showed that he was deficient in cholesterol, or he had too much cholesterol in his eyes. That the doctor that came on virtually recognized this through the exam and said, you need to go see your doctor related to reducing that cholesterol. And he said, well, yeah, I haven't been taking my pills in the last 4 months. So to be able to go into each community, rural or nation, to deliver this type of service and identify health risks associated to not only your eyes, but other health risks, I think is paramount to establishing a virtual type system for areas that can't travel or don't have the technology available to them because of density or population. So it's an exciting project, and we're trying to put.
Yes, yeah. I remember you mentioned imaging facility too, that and they don't have imaging facility, and every time they need, if they need to do ultrasound or other imaging procedures, they have to travel.
Yeah, and so to that for this just the Souk region, not just the Tasauk Nation, is they're traveling basically in traffic about 45 minutes, and sometimes that road system is cut off due to storms or whatnot. But they don't have an ultrasound machine in Souk, and so an ultrasound machine and it ranges anywhere from basically 50 to $120,000, whichever one you derive. But what we can qualify now is if we supply an ultrasound machine to the District of Souk or to the nation in their new health center, we can reduce traffic trips along that road, and we can qualify the net environmental benefit of reducing traffic. So that's going to be part of our grant application to the First Nation Health Authority and to the province and maybe even the federal government. What it does is it opens up different avenues for communities and even say interior health or island health to get solutions to systems that they just basically go to Ministry of Health for, but they aren't realizing that can go to different granting authorities for this type of structure.
Correct. Yes. Well, yeah, thank you. So, our second speaker, I think she has an emergency. Unfortunately, she is not able to join. Dr. Helga Kristen Uvik Provost. I
Good.
see that Diane is here. Diane is from clinical research, and I'm sure that she has many questions for her small community.
I do
But
have a few questions. That's really interesting what you're saying, Dave, because while I have while I work in clinical research in Cranbrook, which is about 2 hours away, I live in Golden, and Golden doesn't have a CT machine. It has one ultrasound machine that is often being used, so there's a long wait, but we have an ultrasound machine. But we are currently trying to have a fundraising gala to raise money so that we can have a CT machine. Once a year, we get a mobile CT machine provided by Interior Health that moves around. But these are really interesting approaches. Like, we've always kind of been banging down the door of Interior Health, Ministry of Health, how can we get these funds? And that's a really interesting approach. Like, think about the other ways that this impacts our entire, region. Because I think when we think about rural areas, we really have to kind of expand. But I've looked up, I'm on your playbook right now. This is thrilling. So I really think this is something that we can do. So thanks for, leading the way on this.
I'm happy to go into further offline as well, Diane. Is that
Yeah.
I'm just looking at the ministries here that are involved in maybe facilitating what you're talking about, and
Mhm.
environmental and climate change strategy. You're talking about
Yeah.
social development and poverty reduction. You're
Mhm.
talking about even tourism. So here's an example of tourism. So uh, I know rural networks well, and I hunt and I fish and I explore and camp and bike and
Yeah.
ski. So when I go up to Tassus, BC, population 300, used to be a mill town of 3,000, they have a wonderful clinic and a helipad. And when
Yeah.
I take my dad fishing to that area, that's one of the first things I did, was that I wanted to make sure that there was a helipad and that there was a medical clinic. And so without a helipad, there's no way I was taking my dad there, because
Yeah.
at the end of the day, he's 90 now. And when I took him up there 4 years ago after major surgery, I wanted to make sure that if in the event he had a heart attack, that we're flying in. Well, not only could we fly in from Tassus, from their helipad, we would actually jump up the queue more so than the wait time that he would be associated with attending emergency down here in Victoria. So I'm not sure if
Yeah.
that's one of your initiatives, but certainly related to tourism, what we're finding in our research and whatnot, and asking tourists from abroad, is that one of their main concerns is the ability to access healthcare. And so I'm a former
Yeah.
president also of Langford Fastball. I coached
Oh.
hockey for 15 years. When we were attending tournaments, it's gotten to a point where I wouldn't send my team to an area that had an emergency that was closed down, right?
Yeah.
So there has to be a tourism component to this. And then you go to the Ministry of Tourism and say, hey, we need to keep this establishment open because of this. We're losing our tourism. And there's grants available, like I say, many different ministries. It's how you associate your ask of your CT scanner associated to
Yeah.
the venue. So I can, I have no doubt in my mind that my team could qualify and prove to your area that with the addition of a CT scanner, you are going to reduce traffic, you are going to reduce the environmental footprint, there's an economic
Mhm.
benefit, and there's also a job creation to that. So now you're going to 4 different ministries with a
Yeah.
qualifying report, not just to the Ministry of Health. It's a different way of thinking about things, right?
Totally. And I think that that's what's really needed, because, the traditional kind of like bang on the door until they listen to you is really not working, is not innovative. We've done it before, right? Yeah.
So it's a different way of banging on the door, but now you're
Totally.
banging on that door with a qualitative report. And part
Totally.
of that report is resiliency planning related to
Yeah.
resiliency for your community.
Yeah, I think Jillian has a question. Go ahead.
Yeah, I think this discussion is really very insightful. Thanks, David and Dan. I just have a quick question about, no, you're talking about imaging, CT scan and such. What's the policy in BC for licensing, getting permission to have your module on site? How challenging is that?
It's very challenging. So when we were dealing with Fort Nelson, uh, I see Diane is they're raising money in their community to afford a CT scanner. Fort Nelson can afford a CT scanner. They already have money in the bank. But what I understand from Fort Nelson, the mayor and the CAO, was that they to facilitate a CT scanner in their area. They had the ability to get a portable, but they weren't allowed to get a portable. But more importantly, they had the ability to create a CT scanner and buy one. But Interior Health, I believe, or whichever health authority wanted them to build an $8 million facility to house this, when in fact there's portable units. So what I've done with the nations here in Tasauk is that because they're nation, because they have a different government that they can basically adopt, the option for the Tasauk Nation is to take ownership of the CT scanner related to a business model that is reflective of their nation, and then service their nation and other nations. But then the secondary option is to facilitate basic, if there's a demand from outside of the non-Indigenous community, then they can facilitate that through their nation on reserve land because it's federal jurisdiction, it's not provincial jurisdiction. And it may have created a bit of a wave or ruffled some feathers. However, it's a means to facilitate better care in the nations and self governments. And it's all about reconciliation. And that's what we're trying to prove in Tasauk. Um, I think it's achievable across BC. And it's just a different way, not only for BC to get better healthcare, but also now because it's First Nations, you're now hitting a different granting authority. You can now go to the federal government as opposed just to the provincial government for the acquisition of CT scanners or ultrasound machines. So into Tasauk, what we're starting with is a small ask of just an ultrasound machine, a business case model for that for the Tasauk Nation. And with the addition of that, we can now service the deficiency in Souk to the non-Indigenous and create a bit of wealth for the nation in doing so and jobs.
So, but the question is now, that's good that you have already financial availability that I have an access to get the machine. But in order to maximize the value, as you said, for the center, you can get access to non-indigenous or the external community. But the question is how you can operate. Do you need issue new license or you need to transfer a license from existing license to the? This is one of the bottleneck we have in Ontario, for example, always.
Yeah, so to that is that it's new ground, Jolly, is that I believe that the jurisdiction and the franchise agreements. So, as an example, in Souk, it's called West Coast Imaging, and they have basically the franchise rights for improvement of imaging in Souk. Well, there's an X-ray machine that I went to when I was 5 years old. I'm 58 now, and I had to go in there 2 years ago, and it's the same machine. It scared me. It's so archaic, right? Should be in a museum. They don't want to expand their services because they don't see the need demographically, because people can travel into Victoria. However, we can prove that the nation, through reconciliation and self-government, has the ability to secure this type of infrastructure, but also I think there's a combination, and this is where Helga at UVic we're trying to work toward, is that we can create a situation where we can now train and educate other individuals, nation members, to become those CT scan people or workers. And I don't see the federal or provincial government saying no to that because we want to create self government, we want to create reconciliation. And this is a way to create economic wealth for the nation, training, education, sustainability. So we're in the early stages of it. Yeah, we're going to have to jump over a few hurdles, I think. But I think those hurdles are worth jumping over to the degree that we facilitate better healthcare for the nations.
If you don't mind, I might jump in here. We have the same issues in Golden here. We foreseeably could have enough money in the coming little while to have a CT machine, to buy one. Our small, very small hospital, which I lovingly call a triage portable with a helipad, can't support a CT machine. So Interior Health says we can't have one because we would need to build a whole facility. And because there's asbestos in the walls, we can't do any changes to the triage portable, and so on and so forth. A external CT machine becomes really challenging in our winters because it would have to be distanced on the other side of the helipad. So then you're taking potentially very seriously injured people outside to another facility. So these are all the issues. I echo them in different places. It must mean that they're happening across the country, in communities that we don't know. And all these kind of things exist. If we had the opportunity to have those smaller care equipment and those, I hear your point, Jaleel, about the licensing. I worked in a different country trying to get a healthcare system established. It was very difficult from a governance perspective. It was in Ethiopia, and their licensing, their kind of agreements with equipment providers and those kind of things was an issue. But I agree that those are not, I won't say smaller because I understand that there's significant challenges to that, but challenges that can be surmounted with time and effort. Also, being able to train people and to have those people in our community creates jobs, creates stability, drives our community forward. One of the big issues that you kind of touched on earlier, Dave, that I thought would be interesting was, the RCMP example. The RCMP provides housing for the people. We need locums here. We need doctors, and we have them. They're spots. They have jobs. They can't find a place to live. There's no network. Like, they're just kind of like posting on Facebook looking for a doctor to rent a room in someone's house. Like, it's
so Diane, to that is that the playbook deals with that. As a population base, it's hard to derive the amenity contribution, such as what I'm talking about in Colwood. But that's not to say that a business plan couldn't be created to prove unequivocally that now you can approach three different ministries, especially Minister of Housing right now, is that we're all talking about affordable housing, but every time I visit, say, Hope had the same issue. They have land available, but they don't have the money available to build the housing. But I could draft up a proposal for you to be able to approach the Ministry of Housing to say we need these locums, and healthcare is an essential service. It's not like other services, so it is essential to emergency planning. So I can guarantee you that if I went into your official community plan or your emergency planning that each municipality has to do, because in Colwood, we've had to declare a state of emergency previous, one related to a snowstorm of 96, and then another windstorm of 2006. So I learned a lot about emergency planning. So I would find in most of the municipalities that I'm working with right now is that they're deficient in their emergency planning reflective of essential service. One of the reasons they're deficient is because they can't supply housing to their volunteers or their nurses or their doctors or their locals. So when stuff hits the fan and you have to declare a state of emergency, how do you draw from something that doesn't exist? So that opens up a different granting authority altogether. Again, now you're dealing with emergency preparedness. It's just a different form and character of looking to solve solutions in a different way rather than just finger pointing at Ministry of Health. It's outside of the box thinking, and
Jalil has a question. I think this is the area that Jalil works, right? Emergency preparedness. Go ahead, Jalil.
Yeah, I think just build on what David said and Dan already initiated about how we can recruit the nurses. I mean, the team of the healthcare professional, just not worried about anything else, but just about the patient and service they provide is very important. So I think we can learn from the GCC area, the country that many Canadian nurses and doctors go practice in Saudi Arabia and Kuwait. And the way they go is they give them for entire, let's say, year, they go for service, they get free shelter house, beautiful condominium, whatever. They get no tax and not, so they're really not worried about anything, and they're happier than go and extend their contract to go there, because the only thing they are worried about, okay, give me a free ticket to go back to Canada, see my family, and come back here. Now in Canada, what we can do. That's important. This is very really disappointing that even if I have a doctor to go to an remote area, and it's a beautiful area, but they worried about where they can stay and live there, and that's such a really bottleneck for us to recruit people, right? So it's very unfortunate, I would say.
Yeah, these days we're worried about everything, right?
But
I mean, government's job is, in my view, but correct me if I'm wrong, government's job is to create environments that people are happy and they thrive. So they focus on good, high quality service. Do we have such thing?
so I think we do. I just think that as a positive way, we need to enhance it, and we need to get back to essential necessities. So right now, in these hard economic times, I think we need to look at essential services related to our emergency planning, related to our growth in our communities. So part of that is approaching BC housing right now that says we need more housing, we need affordable housing. And you look at even the federal government right now is saying we need more housing. Okay, let's get back to the basics. What is essential for a community to exist? It's healthcare, essential service first. So, as an example, and here's a small town, so Cranbrook or Golden. What's happening is those volunteers that volunteer in the fire department are not volunteering anymore because of the cost of living and the cost of housing. So if we can create a situation where we are supplying a house, even at an affordable rate, to those volunteers, they're going to stay and they're going to be retained. Because I can tell you that a full-time equivalent fire person is $200,000. So the tax hit to some of these smaller rural communities is sometimes 4%. 4% being distributed across a small rural community now puts seniors in a position of not being able to afford food or their rent. And then what happens? They go into the hospital system. So our team can qualify that we can prove that supplying housing as locum through the ministries, and then prove to the ministries that, okay, we're reducing the net effect on the hospital system, but by providing essential service providers in a community and reducing the wait times, reducing the hospital stays because our seniors are now being taken care of. We can correlate all that. But getting back to the housing, everybody is talking about housing, but let's talk about essential needs of a community first. And community can apply for housing in a different shape and form. And that's what I'm positioning the smaller rural communities to do.
Yeah, that's a really interesting way, because I think the spin on the emergency preparation really,
Well,
brings it home for like the essential healthcare workers. Yeah.
Not only is it essential, it's a legal requirement that a municipality has an emergency plan reflective of the needs of the community. And so that legal obligation starts with the CAO and then to mayor.
Yeah.
And so I can guarantee you that if I looked at those emergency plans up there, it would be deficient in relation to essential service needs of supplying doctors, nurses, and emergency responders at a point in time where you declare a state of emergency.
I'm just going to Google around our emergency plan.
And it's not just, it's the fact that, and I don't blame any of the local politicians. I don't blame anybody. It's the fact that they don't realize that they can draw from these other ministries or do something in a different form and character.
Hmm.
I've lived this and breathed it, so I have the experience of it.
Yeah. Because I'm my partner used to be a firefighter in a major urban center for a long time. So I'm aware of the cost of a firefighter and the training that goes into them. And then seeing the services that we have here. I mean, most people build their houses with bricks here because they know it's not going to be put out.
But then the fire department services accident scenes now on the highways.
Well, that's what they focus on. It's all Highway 1. It's all keeping Highway 1 open because that is the essential part of our community. And really, to bring it back to healthcare, that's where a lot of our trauma bays are. I mean, essentially, our services are chronic health in seniors, maternity care, and trauma from the highway. That's what our hospital deals in. So interesting. This is a really interesting way of thinking about things. You got my brain spinning, so I appreciate it.
It's different. It's different. It's out of the box, and it's why our former premier, who is a friend of mine, thought it was relevant to share across BC.
Awesome.
Yeah, that's very great. So Diane, did you want to talk about clinical research integration into healthcare? How this is really
Sure.
great. I mean, bridge to build economy-wise, good service-wise, especially when it's sponsored by pharmaceutical companies.
Yeah, I mean, I can. I know this is a little off topic for everybody, but if you bear with me, I can kind of explain. So, yeah, clinical research is mostly an urban center game. It's usually that's where the capacity is, that's where the staff are, that's where the interested physicians are, not that have the ability and the time to be able to devote to this. And so playing the urban game, I mean, I didn't even know this existed. I moved out here just thinking that I would be giving up that my profession of 15 years and looking to do something interesting in terms of government or health or organizing and business wise. I have generated a few businesses in my past. And so I thought I would, smart person, I could figure something out. And then all of a sudden it came to that Interior Health has a clinical trials program that they were trying to get off the ground. And I thought this was really unique. And the more I get involved in rural health, I realize how difficult it is for the providers, for the administrators. It is difficult. It is difficult to be a doctor and go to the grocery store, the one grocery store in town, and get questions about someone's bowels. This happens all the time. And so the providers it's very challenging to recruit here. The providers are overextended because there's 6 doctors in town, those kind of ratios. And then they don't have the capacity to do anything else. They're all burnt out. They are all over it. They're doing the best they can. So finding a physician who is interested in taking the time and taking the administrative effort to look for a trial that would work. And then onboarding everybody at the hospital. We need pharmacy services. We need laboratory services. We need these additional things that are a strain and an over ask for all these services to be able to do. So I was brought on with this amazing physician. Her name is Denise Jaworski. She's an ICU. There are 6 ICU beds in Cranbrook. That is our closest ICU region. We could go into Alberta, into Calgary, but that is a different provincial system, and there's some administrative bumps along the way if we do it that way, which can be done. But usually if we're going that way, it's a helicopter. If we're going to Cranbrook, it's a ambulance. So there can be issues about which way works best either way. Anyways, so we have a physician that's really interested. This is our first clinical trial at EKRH, East Kootenay Regional Hospital. Interior Health at Kelowna Hospital and at Penticton Hospital has small trials going as well. but we were not able to use those trials because we don't have the same resources. We have an ultrasound and a CT machine in Cranbrook, but that is it. We don't have an MRI. A lot of the higher level clinical trials, phase 2, phase 3, require higher level of testing and resources. So we started smaller with a phase 4 study, which means that the drugs are already marketed. They're already drugs that are used in these same purposes. So we're using blood thinners. So these are typical blood thinners that are used commonly all over the place, and they are used to reduce stroke with people that have demonstrated stroke risk. What's different about this trial that we're coming up to is that these drugs are used for if you're in cardiac surgery or you have cardiac issues, and they see things like a flutter or a fibrillation, you would get prescribed this drug for about a year. And it's kind of like a higher dose of like a baby aspirin. So it's just to keep your blood thin to be able to kind of not have these blockages that result in stroke or MI or those kind of things. So it's a very low risk study. All we're doing is now shifting that population from somebody who's had cardiac surgery to any kind of surgery or any kind of acute medical illness. So if you're in the hospital for pneumonia for 6 days and you have a documented flutter, then you could get on this drug and kind of reduce that risk over time, in theory. So that's what we're going to be testing for. So we chose this study because it's phase 4. The drug is this isn't like a first in human vaccine trial, right? We've really, really lowered the barriers so that people are, so that the requirements for our study team are much lower. The other thing we've had to do is look at studies that don't require any kind of lab or any kind of pharmacy requirements above and beyond what would normally happen. So we're actually not even using the hospital pharmacy. We're using outside community hospitals because this drug is covered under MSP. So that's another thing, that this is a academic initiated study. This isn't a pharmacy initiated or a big pharma initiated study, which in our strategy we will get to, but since this is our first clinical trial, we're just trying to increase capacity, kind of ease our hospital into it with this very low risk, very simple study to do. When we've got that under our belts, when we've established some more CRCs, the coordinators that help the team, when we have kind of a greater capacity for people to have training, have had done a clinical trial before, then we will do kind of maybe a phase 3 study, which is Health Canada regulated study. This is a drug that, let's say, insulin is, we know, a marketed drug, but now we're going to use insulin for autism, let's say, and see if that works. So it's a drug that's labeled, but we're using it off label. So that would be an example of a phase 3 study. So we might, and there's more regulations around that and more auditing and inspection. So we would maybe move to a phase 3 study as long as we can find one that works with the abilities that we have and the resources that we have, which includes staff. We need educated staff on site that would be able to do that. And then overall, the strategy would be then once we have this capacity built in both kind of knowledge and expertise, then we would go after big pharma studies. There's a two-way kind of reciprocal relationship there. The big pharma sees that we've done trials before. They trust us that we can deliver on our results. They believe us when we say we have a patient population that can support their study. And then also, pharma studies pay more. They're able to pay things like a whole clinical research coordinator, and then we can use some of that clinical research coordinator's time to do other studies that are we are more interested in. So we kind of use this Robin Hood model to kind of use big pharma to be able to offset our more academic focused clinical research. What we're also doing, which I've never done before in clinical research, is involving patients, which sounds ridiculous that this is the only time that we're involving them. But in an urban center, we had a clinical trial research committee or a board, and they never had patient partners in it. It was all doctors around the table looking about how many SAEs, how many serious adverse events, how many protocol deviations, who should have a study, what's coming down the tubes. There was no patient being like, hey, I have Crohn's. Is there a Crohn's study coming along? I'm really interested in this. So we've made a board that is basically all patient population. We've had to educate this population about what a trial is, how it works, all these kind of things. We've made values, we've come up with a mission statement, and we are now evaluating trials as well as if we can physically do them, if they had the resources and all those kind of things, but whether or not this project matters to our community. So these are kind of the things that are going on. So I'll
Yeah,
stop
I
there.
think you're just awesome. You're doing great job, Diane. Because clinical research it actually strengthens healthcare system, right? By
Yeah,
improving
absolutely.
patients' care.
Well,
Yeah.
and everyone says that healthcare needs to be innovative, and then we just keep on doing the same
Yeah.
things. And
So there
everyone's
you
like,
go.
I have an idea, and then it's not going to happen. So we're kind of pushing through it. And I also think there's a big part of equity in this. You know, we bring new drugs into the system and we have no idea if they'll work for a rural community. If someone has to drive in every day to get their, medicine, is that feasible for every person in Canada? Just very interesting, this rural world that I've dropped into. So, but I appreciate this talk, and I was just here to listen, but I'm happy to babble on.
No, you're experienced clinical researchers. I also come from clinical research. Jalil is in R&D. I believe clinical research strengthens the our healthcare system by driving innovation and improving patient care and building, capacity, building local expertise. It's very, very important that always we integrate clinical research in our hospitals. So I think it's 101. As we wrap up, I hope that this webinar sparked ideas.
It definitely did.
Yes. Yeah. Well, thank you so much, Dave. And thank you so much, Diane, Arman, and Jalil for your contribution. Hope to see you all again in our next webinars.
Awesome.
Thank you very much.
Thank you, Dave.
And please reach out to me. I'm happy to talk to you offline and some options for your towns and whatnot.
Yeah, I'll take a cruise through some stuff and get at you with a couple questions or insights. I would love to. I think a lot of the kind of questions we're talking about are a little bit above my pay grade, but it doesn't mean I can't put it in somebody's ear.
You know what? It's set collective impact. It's about empowering
communities
with different solutions and innovation. That's what we're all about. And I'm happy to facilitate a webinar related to your councils up there or whichever.
Oh, great. Okay. Awesome. Well, thank you. Shelley, have a wonderful rest of your afternoon. Dave, you've got a little bit more time on us, so enjoy the rest of your day.
Thank you very much. Shelley,
Yes,
thanks.
correct. Yes. Okay. Bye-bye.
Bye.